Welcome to Module 3. In this unit, we will discuss the multiple types of equipment used in the delivery of IV therapy. This unit corresponds to Chapter 5 in your textbook, The Manual IV Therapeutics by Phillips and Gorski. Infusion therapy involves the use of many types of equipment and often complex technology. Equipment includes single-use devices such as disposable solution containers, tubing and catheters, and durable medical equipment such as infusion pumps, IV pulls, and visualization technology such as ultrasound units. It is important that nurses are well educated and competent in clinical application and proper use of equipment. Let's begin with the infusion delivery system or solution containers. The two types of solution containers we will discuss in this unit are the glass and plastic containers. In general hydration, electrolyte solutions, medications, blood products, and nutritional products are made of either plastic or glass. Although today the use of glass containers is relatively rare, glass is still used for medications or solutions that are not compatible with the chemicals or properties of plastic. Glass containers are available in the U.S. and are not just made of glass, but a combination of glass, plastic, rubber, and metal. Keep in mind that because glass cannot be collapsed, it is required to open the vent to allow air to enter the bottle during infusion. A vented administration set must be used with glass bottles. Please see Figure 5.1 on page 244 for the comparison of glass and plastic infusion delivery systems. In this figure, it's illustrated the vented administration set and the non-vented administration set. The glass system is a closed system that has a rubber stopper, also called the rubber bung. The rubber bung is covered with a removable seal. During insertion of the spike of the administration set, coring can occur, which results in the introduction of fragments of the rubber core into the solution. Therefore, in order to ensure safety in the administration of solutions, the nurse must check the clarity of the solution and the expiration date before connecting it to the administration set. To check a glass container, hold the glass bottle up to the light and check for flashes of light, floating particles, or discoloration. The solution should be crystal clear. The advantages and disadvantages related to the use of the glass system are listed in your book on page 245. Crystal clear, which allows good visualization of contents, graduations on glass easy to read, inert, has no plasticizers, are all advantages of using the glass system. Disadvantages include they are more easily broken during transport, there are storage problems, particulate matter due to coring, cumbersome disposal, rigidity, and container constructed of mixed materials. Most infusate solutions are packaged in flexible or semi-rigid plastic containers. Page 247 of your text provides illustrations of plastic infusion systems, both large volume plastic containers and secondary solution containers. Flexible plastic containers have several unique features. First, the entire structure that comes in contact with the IV solution is made of the same material. The most common plastic used in solution containers is polyvinyl chloride, or PVC. Plastic containers are provided in 1,000 and 500 milliliter bags for primary infusions and also comes in 50 to 150 milliliter bags for secondary infusions. Larger plastic bags up to 4,000 mils are available for mixing large volume infusions such as TPN. Since plastic containers are collapsible and do not need air to replace fluid flowing from the container, it doesn't require a vent. Therefore, a non-vented administration set is used. Depending on the manufacturer, there may be one or two extensions or entry ports protruding from the bottom of the bag. If there are two, one is the administration set port. This is where the spike of the administration set is inserted. The port is covered with removable plastic pigtail that maintains the port's sterility before spiking with the administration set. The second port is the injection port for adding medication. A membrane seals both the medication and the administration ports of the container, and entry of air into the system is prevented. Spiking the plastic container is done by a simple twisting motion. Because the plastic can be easily perforated during use, careful attention should be paid to the integrity of this container during preparation and infusion delivery. To check for clarity, the plastic container should be held up to the light and checked. Check for discoloration or floating particles in the solution. If present, it should not be used and should be considered potentially contaminated. Also, squeeze the plastic container to check for pinholes and thus leakage and loss of integrity. Check for the expiration date on the label to ensure patient safety, and be sure the outer wrap of the plastic is intact. Keep in mind that administration sets are manufactured with varying materials. The common types are PVC or non-PVC. Information related to the materials that make up the administration sets are listed on page 250 in your text. Although this is good information, you will not be tested on it. Now let's look at the basic components of administration sets. The most frequently used administration sets are the primary set, which is used for primary infusions. We also use secondary sets, which are used for administering IV antibiotics and other IV medications. And finally, the Y set, which is used for blood and large volume infusions. All three have the same basic components, but may vary in drop factor and also the length of the tubing. The spike is the sharply tipped plastic tube designed to be inserted to the solution container. It is connected to the flange, drop orifice, and drip chamber. Next is the flange, which is a plastic guard to help prevent touch contamination during insertion of the spike. The arrows in figures A and B are pointing to what is called the drop orifice, which is an opening that determines the size and shape of the fluid drop. The size of this drop orifice determines the drop factor. The drop factor provides the information that we will use to calculate infusion rate by gravity. If you look closer, the drop orifice in figure A is round with a bigger opening than the one in figure B. The drop orifice in figure B is a size of a needle. Figure A is known as a macro drip set, and figure B is known as a micro drip set. A macro drip set delivers the bigger drip. These are the drop factors of 10, 15, and 20 drops. That means that it takes 10 drops to make 1 mil, or 15 drops to make 1 mil, or 20 drops to make 1 mil. The micro drip delivers a smaller drip, and there's only one type. It's the drop factor of 60, which means it takes 60 drops to make 1 mil. The figure in the far right is pointing to the number 20 as a drop. So that infusion set is illustrating a 20 drop set. The drip chamber is a pliable and large clear plastic tube that contains the drop orifice and allows for visualization of the following drops. It is directly connected to the tubing. Next is the tubing. The plastic tubing connects to the drip chamber. Depending on the manufacturer, the tubing may have a variety of clamps, connectors, or filters built into the system. The average length of primary tubing can be from 66 to 100 inches, and the average length of secondary tubing can be 32 to 42 inches. The flow clamp control device operates on the principle of compression of the tubing wall. The roller clamp is found on all the tubing as the clamp is tightened. Some sets also include a slide or pinch clamp that often is used as on-off controls and are never used to regulate flow. Injection ports serve as an access into the tubing and are located at various points along the administration set. Usually the ports are used for medication administration. The back check valve is a one-way valve that allows the solution to flow in one direction. Most often it's used with secondary administration, allowing the primary solution to resume after the piggyback is complete. The hub, illustrated here as a needle end, is the adapter to connect the administration set to the IV catheter or needleless system. It is also called the male lure lock or lure slip. The final filter removes foreign particles from the infusate or solutions. It may be an integral part of the administration set, or it may be added separately. The main point to remember about infusion sets are that there are different types of infusions, and the type of infusion dictates what administration set is needed to deliver the IV infusion appropriately. Recall that primary sets can be vented or non-vented. Vented primary sets are used for glass containers. Primary sets are available as macro drips, so they are 10, 15, or 20 drops per milliliter, and that is used for large volume infusions. The size of the drop is clearly specified on the packaging of each administration set. The microdrip set provides smaller drops, like 60 drops per milliliter, and are used for patients with fluid intolerance, so it will produce a small volume infusion. Primary continuous administration sets are the main administration used to deliver solutions and medications. Again, they are available in vented and non-vented. As Ohio licensed practical nurses authorized to practice limited IV therapy, you will be working with this type of tubing. The tubing of the set distal to the drip chamber terminates in a male Luer lock end that connects to the vascular access device hub or needleless connector. For additional information regarding primary sets and primary infusions, please refer to your textbook on pages 254 and 255. This slide illustrates the differences between macrodrip and microdrip infusion sets and indicates the advantages and disadvantages of each. For the macrodrip, the advantages are it allows fast fluid infusion, allows fluid resuscitation, and allows fluid boluses. Disadvantages are potential for fluid overload, and it's difficult to titrate. The microdrip advantages are easy to titrate and avoids fluid overload. Disadvantages are it doesn't allow for resuscitation and it does not allow for fluid boluses. A secondary administration set is defined as an administration set attached to the primary administration set for a specific purpose. Usually it's to administer medications. It is also commonly called the piggyback set. The piggyback set has a short tubing with standard drop factor of 10 to 20 drops per milliliter. It is used to deliver up to 500 milliliters of an infusate. These sets are widely used for the administration of multiple drug therapies to patients. They are connected with a needleless adapter into an injection port immediately distal to the back check valve of the primary tubing. In setting up the piggyback set, the primary infusion container is positioned lower than the secondary container using the extension hook provided in the secondary line packaging. As Ohio LPNs authorized to practice limited IV therapy, this is another type of tubing you will be working with when administering antibiotics. It is important to keep in mind that with every connection and disconnection, there is a risk for contamination at the catheter hub, the needleless connector, and the male Luer end of the administration set, which increases the risk for bloodstream infection. Always use aseptic techniques with each access and careful attention to protecting the male Luer end of the set. Always put a new sterile compatible covering device after each use. An example of an antimicrobial product used for the purpose of protecting the end of the tubing is shown on page 256 and figure 9 in your book. Also, current INS standards at this time indicate that administration sets should be changed every 24 hours. The primary Y administration set is used for rapid infusions or for administration of more than one solution at a time. Each Y of the solution is capable of being the primary set. There are two separate spikes with a separate drip chamber and short length of tubing with individual clamps. They are made up of large bore tubing. The purpose of this tubing is to infuse large amounts of fluid in acute situations. One thing to keep in mind is the risk for air embolism, because air can be drawn into the administration set if one container is allowed to empty. In checking and troubleshooting your IV infusions, it's important to understand flow dynamics. This is impacted by pressure, gravity, flow, the height of the infusion container, clots in the catheter, and changes in position in the catheter. The following are the standards of practice for administration sets based on the INS. Continuous administration sets are changed every 72 hours, changed immediately upon suspected contamination, and changed when integrity of the product has been compromised. Primary intermittent administration sets are changed every 24 hours, changed immediately upon suspected contamination, and changed when the integrity of the product has been compromised. Administration sets that are used to accommodate blood or blood components shall be changed after each unit or at the end of 4 hours. When add-on devices are used, they should be changed with each catheter or administration set replacement, or whenever the integrity of either product is compromised. A 0.2 micron filter is considered a bacterial particulate retentive, air eliminating filter, and is recommended for use to decrease potential of air emboli. To achieve final filtration, the filter should be located as close to the cannula site as possible. The filter should be an integral part of the administration set. During the skills practicum day, you will have an opportunity to practice setting up the administration set. Next, we will discuss peripheral infusion devices, the major types. We will be discussing over-the-needle, winged, and scalp vein needle types. The most widely used infusion device is the over-the-needle catheter, which consists of a flexible catheter in tandem with a rigid needle or stylet that is used as a guide to puncture and insert the catheter into the vein. The stylet connects with a clear chamber that allows for visualization of blood return, indicating that your venipuncture has been successful. The hub of the catheter is plastic and color-coded to indicate length and gauge. The length can be anywhere from 1/2 inch to 3 inches, and the gauges are at even numbers ranging from 12 to 24. After the venipuncture, the needle is withdrawn and discarded, leaving a flexible catheter within the vein. Over-the-needle catheters can remain in place for several days. Keep in mind, with any catheter, you use the shortest length and the smallest gauge to deliver the ordered therapy. Also, use a vein large enough to sustain sufficient blood flow because this will decrease irritation to the vein wall. This illustration shows the different parts of the over-the-needle catheter. At the top is the hub, followed by the shaft, the beveled edge, and the lumen. Next, we will talk about the winged, or what is also known as the butterfly or scalp vein cannula. Flexible plastic wings extend from either side of the needle hub, and a short length of tubing is attached to the needle. This device is great for obtaining blood. It may also be used for a single-dose IV medication administration, but needs to be promptly removed because it is never left in place due to the risk of infiltration. Stainless steel needles are available in the following gauges, which are odd-numbered, 17 through 27, and in lengths from 0.5 to 1 inch. The wings attached to the shaft are made of rubber or plastic, and the flexible tubing extending behind the wings varies from 3 to 12 inches in length. Additionally, this type of catheter may be utilized in the pediatric and neonatal population. The next type is called a midline catheter. The midline catheter is a longer peripheral IV catheter placed in a peripheral vein, generally inserted in the antecubital fossa, with the catheter tip residing below the axillary line. In infants, a midline catheter may be placed in a scalp vein with the tip terminating in the external jugular vein. Midline catheters are any catheter placed between the antecubital area and the head of the clavicle. They're designed for intermediate therapy up to 28 days. Catheters are usually 6 inches long and made of elastomeric hydrogel. Approximately 2 hours after insertion, becomes 50 times softer and increases 2 gauges in size and 2.5 centimeters in length. Some standards of practice to keep in mind for IV needles are that the cannula should be the smallest gauge and the shortest length to accommodate the prescribed therapy. The catheter should be radiopaque, which means that we can see the catheter up on an X-ray. They should be 3 inches in length, so they're shorter. The cannula should be made with a stainless steel needle. And the choice of catheter and appropriate nursing care for midline catheters should be established in organizational policy and procedure. When preparing to insert an IV, it's important to gather your supplies ahead of time. This includes gloves, tourniquet, tape, dressing, gauze, alcohol prep, the IV catheter, connector tubing, a saline flush, your drip set, and your IV fluid. Next, we will talk about central infusion devices or central vascular access devices. These are defined by the location of the catheter tip in a central vein. The tip should reside in the lower 1/3 of the superior vena cava above the right atrium. A percutaneous catheter, also known as a non-tunneled central vascular access device, is placed by an infraclavicular approach through the subclavian vein. Other sites where you might see a percutaneous catheter are in the jugular or femoral veins. The final tip location should be in the SVC, provides access to larger venous circulation for the infusion of hypertonic solutions. This can be placed at the bedside by a physician only. A peripherally inserted central catheter, or PICC, can be placed at the bedside as well. It is a common type of central vascular access device used in all settings, including the acute, long-term, and outpatient and home care settings. The PICC may be placed for short-term needs in the acute care setting and may be used on a longer-term basis for patients who require longer-term infusion therapy outside of the hospital. The PICC is usually placed in an insertion site above the antecubital fossa, via the cephalic, basilic, or median veins, and threaded to its central location in the superior vena cava. It comes in sizes from 16 to 26 gauges and 50 to 60 centimeters in length, or 20 to 24 inches. It's used to deliver all types of IV solution and may also be single or double lumen. Another type of catheter is the central venous tunneled catheter. These are surgically placed central vascular access devices. They are placed in the operating room or in the interventional radiology suite. The tunneled catheter is considered a long-term catheter for patients who require lifelong or long-term infusion therapy, such as total parenteral nutrition or chemotherapy. The catheter is tunneled in the subcutaneous tissue between an entrance and an exit site. The exit site is where the catheter extrudes, usually in the lower area of the chest. The entrance site is where the catheter enters the venous circulation, generally near the clavicle, and will appear as an incision. A cuff is attached to the catheter and located in the tunnel. Over time, tissue attaches to the cuff, stabilizing and holding that catheter in place. The tunneling or cuff also serves to seal the path from the exit site to the vein, thus reducing the risk of bloodstream infection. You may hear them called Groshong, Hickman, or Broviac, and those are named after the various physicians who developed them. They can be anywhere from 20 to 30 inches long, and their gauges can be 22 to 17 internal lumen diameter. This slide shows the triple lumen catheter in its insertion, and then as it passes near the collarbone or clavicle and into the exit area. The triple lumen catheter is a type of percutaneously placed catheter that is non-tunneled. This picture illustrates the triple lumen catheter as it is anchored in. Notice the sutures placed where it enters the skin. Another type of catheter is the implantable venous access port, which provides a completely closed system that is surgically placed in a subcutaneous pocket with a drug reservoir, or what is also known as the port, and it is a self-sealing system. It can withstand up to 2,000 needle punctures. We use ports for blood withdrawals, hypertonic IV solution infusion, blood transfusions, and chemotherapy. We use what is called a non-coring needle only to access the port. You may also hear this called the Huber needle, which can come as a straight needle or one with a 90-degree bend. It comes in sizes from 19 to 24 gauge and can be 1 to 2 inches in length. Please keep in mind that the Huber needle, or the non-coring needle that we use to access the port, is often
can often lead to needle stick injuries. So make sure that you are using appropriate safety precautions when utilizing these needles. This picture illustrates a woman with an implanted catheter subcutaneously on the right upper portion of her chest. And the next picture to the right shows the access needle being placed into the septum of the port. Next, we will talk about flow control devices or infusion regulation devices. Mechanical or gravity devices are set manually. They deliver specified volumes of fluid per hour and are available as dials, clock-like faces, or a barrel-shaped device with cylindrical controls. This is a picture of a manual control rate flow regulator. Electronic infusion devices are powered by electricity or battery and are programmed to regulate the IV flow rate in either drops per minute or milliliters per hour. They use positive pressure to deliver the infusion. It is important to recognize the occlusion pressures are a safety feature, and nurses should be cautious when changing the pressure to avoid setting off alarms. Controllers operate strictly on gravity flow. They do not exert positive pressure other than the height of the bag. Max flow rate depends on height. You cannot detect infiltrations. They do have drop sensors and electric mechanisms to regulate the gravity flow of fluid and will alarm with resistance. They reduce potential for rapid infusion in empty bottles. Hang the IV bag 36 inches above the patient's head. Positive pressure infusion pumps average 10 psi. They are used for delivering high volumes of complex therapies and are more precise than controllers and totally control the flow rate. Volumetric pumps calculate the volume delivered by measuring the volume displaced in a reservoir that is part of the administration set. These are used in the neonatal, pediatric, and ICU settings and can also be used for blood administration. They require special cartridge tubings and exert 2 to 10 psi. Peristaltic pumps provide intermittent squeezing of IV tubing, allowing for intermittent pressure. These are primarily used for enteral feedings. Syringe pumps are piston-driven. They're valuable for critical infusions of small doses of high-potency drugs. The volume is limited to the size of the syringe, which is anywhere from 5 milliliters, which you might find in a neonatal setting, to 60 milliliters. Patient-controlled analgesia pumps deliver analgesia through the IV via the epidural or subcutaneously. They have remote bolus control and must be programmed with parameters to prevent over-medication. There's also multi-channel and dual channels, which deliver several medications or fluids simultaneously. There's also ambulatory pumps, which are lightweight and have a limited power supply. And of course, there are also disposable pumps, which are balloon pump systems, and those are used for antibiotics primarily. Things to keep in mind about the electronic infusion devices are that you must guide your practice with them with patient age, condition, and prescribed therapy. They provide accurate flow rate. They are easy to use, and they have alarms that signal problems with the infusion. You still must assess hourly. When using electronic infusion devices, you need to know the indications for their use, the mechanical operation, how to troubleshoot, their PSI rating, and safe usage and handling guidelines. This picture is an example of a dual pump you might see in your setting. Notice that on each side of the control panel that says pump 1 and pump 2. So you are able to infuse 2 different solutions at the same time. These are also examples of other common electronic pumps that you might see in the work setting. The one in the top left is the Alaris pump, and you can add different modules to the pump. It just doesn't do 1 or 2. You can add several of them, and those are utilized in the ICU setting when you have several drips going at once. And then the bottom right is the syringe pump, and notice that the syringe is in place of an IV fluid bag. Some standards to keep in mind for use of infusion devices are a flow control device is used to assist in regulating a prescribed administration rate. Manual flow control devices should achieve accurate delivery of prescribed therapy with minimal deviation and are an adjunct to nursing care and are not intended to alleviate the nurse's responsibility for actually monitoring the flow rate of the therapy. Electronic devices should be used when warranted by the patient's age, condition, setting, and prescribed therapy. The nurse is still held responsible and accountable for the use of electronic devices. Here are some definitions that are important in understanding infusion terminology. Rate is the amount of time over which a specific volume of fluid is delivered. Volume infused is the measurement that tells how much of a given solution has been infused. This measurement is used to monitor the amount of fluid infused in a shift. It can also be used in home health to monitor the infusion periodically during the day or over several days. The volume to be infused is the amount of solution hanging in the solution container, usually. A pump is designed to sound an alarm when the volume to be infused is reached. Air in the line is designed to detect air in line and may include air detection and air removal. Occlusion detects absence of fluid flowing upstream between the pump and the infusion container or downstream between the patient and the pump. Infusion complete is an alarm triggered by a preset volume limit. And low battery or low power gives the user ample warning of the pump's impending inability to function. There are various types of accessory equipment that might be utilized with infusion therapy, and it will depend on the type of equipment that you have at your facility. Things such as filters, HEP locks, additional add-on devices, needleless systems, stopcocks, and extension tubings will be available for use depending on your site of work. In this slide, you'll see examples of latex resealable locks, which are on is the picture on the bottom, and needleless systems, which is the picture on the top. These particular devices allow access to the administration set so that if you needed to add additional medication or drugs, or to connect your administration set to the hub of your catheter. That's what these types of accessory equipments are utilized for. There are various types of filters available depending on the IV administration set, the manufacturer, and policy. And these are designed to prevent passage of undesirable substances. Stopcocks are used to regulate flow in one direction or the other, so that if you have multiple sites of administration, you can generate the appropriate flow of infusate or solution. This slide illustrates extension tubings, which are sometimes added at the site of the catheter to extend the length of the tubing set. This slide illustrates some potential nursing diagnoses related to IV therapy: risk for injury, knowledge deficit, anxiety, and impaired physical mobility. This concludes Module 3 of your IV therapy course.